Good afternoon, everyone. My name is Dr. Subasri Narasimhan, and I'm an assistant professor here at Emory University, and I'm also the advocacy chair of the Women in Global Health Georgia chapter. I'd like to thank you all for coming this afternoon and joining the Women in Global Health Georgia chapter for this webinar entitled 5 Months Post-Roe, How Restrictive Abortion Policy is Shaping Healthcare in the U.S. We'd like to thank the Women in Global Health Washington, D.C. chapter for partnering with us today. And we would also like to take this moment to acknowledge the loss of WGHDC's founder and first chair, Nicole Sheig. Nicole was a renowned global health strategist, advocate, and advisor, and she founded the C5 Collective to end childhood preventable deaths. In the chat, I'm going to place more information about Nicole's life and legacy, and I'm hoping that we can take at least 1 minute in silence to honor her work. Thank you again to Women in Global Health DC for partnering with us today, and thank you everyone for joining us for this webinar. So I'd like to move on and acknowledge that we all are coming to this space for different reasons on this post-midterm election day. And I want to appreciate everyone for taking time to attend and attend in whatever way that you can. Please take care of yourself. Feel free to take a moment to step away if there's anything in this webinar that might feel heavy or triggering, but we're hoping to have a really great and rousing conversation during this lunch hour. So I'd love to introduce our speakers. We have a great group of panelists, and our first speaker is Dr. Sara Redd, who is a postdoctoral fellow with the Center for Reproductive Health Research in the Southeast, and also the Department of Health Policy and Management at Emory University. Dr. Redd is an interdisciplinary scholar of domestic, sexual, and reproductive health, health equity, and her research agenda sits at the intersection of health policy and social science, with an explicit focus on examining the effects of domestic, sexual, and reproductive health policies on the health and well-being of people who are capable of becoming pregnant in the US. Recently, her work has focused on documenting the effects and harms of restrictive laws on maternal mortality and abortion, both nationally and here in the state of Georgia. And our second speaker, Dr. Nisha Verma, is an obstetrician gynecologist, complex family planning specialist, and clinical researcher committed to improving the access to abortion care in the US, the Southeast, which she has called her home as a proud Southerner. She served as a Darney Landy Fellow at the American College of Obstetricians and Gynecologists, where she was and continues to be actively involved in abortion-related policy and advocacy work. And Dr. Verma has provided abortion care at Planned Parenthood in the Delaware area, and currently provides abortion care here as an assistant professor in the Department of Obstetrics and Gynecology in the Division of Family Planning at Emory. Dr. Verma's research work is particularly related to qualitative research, and her abortion-related research is in restrictive contexts, looking at the intersection of policy, advocacy, and research. She is hoping to improve exploration of the impacts of changing legal landscapes around abortion on people in the US and the Southeast, especially amongst communities that are already marginalized or marginalized from care. And she's hoping as a clinician that she can better support people who are self-managing abortions and also coming to the healthcare system for care. Thank you both for attending. I think we're going to have Sara come on to video and begin. Thank you so much.
Thank you. I'm going to if I can start sharing my screen. Alrighty, so thank you, Dr. Narasimhan, and to the Women in Global Health chapter, the Georgia chapter, and the DC chapter for having this conversation today, which is just becoming, has always been important, but it's just becoming increasingly important. Yeah, I'm just so happy to be here. So thank y'all for hosting this panel. So good afternoon. Yes, my name is Dr. Sara Redd, and I am a postdoctoral fellow at the School of Public Health at Emory. And my kind of portion for the day today is to talk more about much of my work, which, as Suba mentioned, is focused on evaluating the implications of restrictive abortion policies. So I'm going to start off with a little bit of grounding, which you all will definitely get more of hearing Dr. Verma talk, but I'll provide a little bit of grounding and then go into some examples of what we've seen both in research that I've conducted and just kind of in the larger literature of what we know that these restrictive abortion policies do, and then talk about kind of what that means for the future in this post-Roe setting in which we are currently in. So to provide a little bit of grounding, first I want to just talk a little bit about abortion in the US. So abortion is a common pregnancy resolution option that's available to people experiencing a pregnancy. In 2020, roughly 21% of pregnancies ended in abortion. Abortion is also exceedingly safe, with the risk of major complications from a first trimester abortion being well under 1%. As you can see in this graphic here, the number of abortions provided in the US has steadily declined since around the 1980s, from the 1980s to about 2017, where it hit actually a historic low. But from 2017 to 2020, the number of abortions actually increased by 8%, which kind of reverses this long-term trend that we've seen of declining abortion in the US. As will likely come as no surprise to you all, since Roe v. Wade was decided in 1973, there has been an immense influx of federal, but primarily state level legislation restricting access to abortion care. And that has been primarily concentrated over the last 10 to 15 years, in which, and during the last decade alone, over 600 state level restrictive abortion policies were passed, which comprises about 46% of all restrictions that have been passed since Roe v. Wade. I will highlight that this graphic, which was created by the Guttmacher Institute, was created and posted 3 days prior to the SCOTUS decision in Dobbs versus Jackson Women's Health Organization. So this graphic does not include the many hyper-restrictive laws, including total abortion bans that have been enacted and implemented since that day, since June 24th, 2022. To give kind of an understanding of how restrictive abortion policies influence abortion access and care, I just kind of want to talk about a policy as an upstream determinant of healthcare. So it's a kind of structural level factor that affects an individual's ability to access care and then their subsequent health outcomes. So what we know from the literature and from people's lived experiences of seeking abortion care is that restrictive abortion policies do three main things. First, they severely reduce access to abortion care through mechanisms like decreased provider availability, increased difficulty to actually get an appointment, and additional barriers to care, including increased travel time, increased distance, and costs of trying to get care, which of course have only increased now that so many states have, these increasingly restrictive settings. Additionally, restrictive abortion policies both directly and indirectly increase risk for adverse birth outcomes, including things like preterm birth, low birth weight, and infant and maternal mortality. Lastly, these policies function as tools of white supremacy in that they disproportionately affect and devalue the health of those with the least amount of power in society, including Black people and other people of color, younger people, and people with fewer socioeconomic resources. Now I'm going to, if I can get my slides to progress, I'm going to walk you through probably a little quickly because I tried to fit too much information in a short amount of time. But I'm going to give you all a kind of brief overview of what we know, kind of the implications of these restrictive policies in a pre-Dobbs world, if you will. And then we'll talk a little bit more about this post-Dobbs or post-Roe landscape now. Just to start, one of the very common types of restrictive abortion policies that state legislatures have used to restrict access to abortion is through gestational age limits. And gestational age limits are essentially limits past which the gestational age of pregnancy, past which you're no longer eligible to receive abortion care. So that's going to be very common for some of the studies that I'm talking about specifically here in Georgia. So this first example is some work that I and some of my colleagues, including Dr. Narasimhan at RISE, conducted to evaluate Georgia's 22-week gestational age limit, which bans abortion past 22 weeks gestation from an individual's last menstrual period. This policy was a little complicated because it was passed in 2012, but then underwent a series of a 3-year, essentially, period of litigation, but ultimately was fully implemented in late 2015. What we tried to evaluate was we looked at the number of abortions provided in Georgia at or after 22 weeks from 2007 to 2017. So kind of this nice long period during which we were experiencing these changes in Georgia's restrictive abortion policy. And if we look at the black line, which indicates the number of abortions at or after 22 weeks in the state of Georgia, if you follow that black line, if I can find my mouse, if you follow it from 2007 and then into this partial implementation period, which we won't really talk about today, but then looking at once the policy was fully implemented, we saw that this policy resulted in the number of abortions at or after 22 weeks declining to virtually zero. So this ban, as it intended, eliminated access to abortions at 22 weeks or more. One thing that's really important about abortion in Georgia is that Georgia has long served as a hub for abortion in the South, namely because although Georgia is a restrictive setting, it's less restrictive than many of the surrounding states. The next piece of what we wanted to look at in this analysis was comparing abortions provided to Georgia residents and people who are coming from out of state. So if you look at the red line, which represents abortions at or after 22 weeks provided to people coming from out of state, to the blue line, which is abortions at or after 22 weeks for Georgia residents, you can see that there's actually a larger number of abortions being provided to people coming from out of state. And when you kind of compare the declines of the two, we can see that that out-of-state residents actually experienced a steeper decline in abortions at or after 22 weeks compared to Georgia residents, which ultimately goes to show that what happens in one state affects people that are living in other states. And in this specific example, what happens in one state affected an entire region. But when we look at that overall picture, we don't really get details on how this policy has the potential to affect Georgians differently. And to be more explicit, we don't really see how these policies function how these policies are essentially tools of structural racism and classism. So in a second follow-up study, we examined racial and ethnic inequities in the effects of the 22-week ban here in Georgia. And if you focus on the black line and the red line, which show the abortion rates at or after 22 weeks for Black and white people respectively, you can see that the decline in the abortion rate was much steeper for Black people compared to white people, which provides very clear evidence that this 22-week ban disproportionately affected Black pregnant people. Moving more now into kind of what are the health outcomes that people can experience from not being able to access abortion. There's a growing literature base that is focusing on this relationship. And first, what we've seen is relatively across the board, these studies have shown that an increased, a more restrictive setting leads to more poorer birth outcomes. So for example, there was a study comparing infant mortality rates between restrictive states and less restrictive states. And this study actually found that there was an 8 to 10% increase in infant mortality for people living in restrictive states compared to non-restrictive states. Similarly, there have been studies that have shown that there's a increase in maternal mortality for those living in restrictive states versus non-restrictive states. And then on the flip side of that coin, in terms of low birth weight, there have been studies that have indicated that actually there's a decrease in low birth weight rates for people living in the least restrictive settings compared to those living in the most restrictive settings. However, because we live in a white supremacist and capitalist society, these policies function, again, as tools of white supremacy, and that they disproportionately affect those with the least amount of power in our society. So what this looks like in some of our birth outcomes related to restrictive abortion policies is that we've seen that these policies disproportionately affect people of color and people with lower socioeconomic status. So in terms of preterm birth and low birth weight, we've actually seen that there's a 3 to 5% higher risk of those outcomes among Black birthing people and birthing people with fewer years of education as they live in more restrictive settings. And then similarly, kind of the flip side of that, there's actually a lower risk of low birth weight among Black women who are living in least restrictive settings compared to those living in the most restrictive settings. So I'm getting, my time is moving quickly, so I'm going to focus a little bit more about now kind of like what we know is happening now and what we can kind of predict for the future in this post-Dobbs or post-Roe world. So when the Supreme Court overturned Roe v. Wade, when they issued their ruling in the Dobbs case, that provided the legal precedent for both states to enact complete abortion bans that have either been on the books since prior to Roe v. Wade, or were what they called trigger bans, which were allowed to go into effect immediately once Roe v. Wade was overturned. But additionally, that ruling provided the legal precedent for some states to enact hyper-restrictive early gestational age bans, which is what I'm going to focus on here in Georgia. So you may have heard of Georgia's 6-week ban or heartbeat bill, and this is referring to a law called HB 481, which is House Bill 481. Okay, thank you, Suba. Which is a fetal cardiac activity ban. And what that essentially means is that, there's the name of a 6-week ban is actually a little bit of a misnomer because these policies do not actually, in the law itself, it does not say we are banning abortion at 6 weeks gestation, but they actually use language that's much more vague and complicated, and which has implications for affecting clinical care. However, what the kind of marker that this law uses is that they ban abortion past the point at which fetal cardiac activity can be detected. Often that is typically detected by about 6 weeks, but that's not a firm, it's not a, there's no clear gestational age at which that happens. So to give you kind of a very brief background, HB 481 was signed into law in May of 2019, but was preliminarily enjoined in October of 2019 in the lawsuit Sister Song versus Kemp, prior to the enactment or the effective date. It was supposed to go into effect on January 1st, 2020. The law was permanently enjoined by a lower court in July 2020. Of course, the state appealed that decision, and where the lawsuit actually was then essentially the judge just said, okay, we're going to wait and see what SCOTUS says in the Dobbs case. Unsurprisingly, the Supreme Court overturned Roe v. Wade in the Dobbs decision, which then provided the legal precedent for the 11th Circuit Court of Appeals to vacate the injunction on HB 481, and the law was actually allowed to go into effect that afternoon on July 20th. We then at RISE wanted to understand, okay, using the data that we used from the 22-week ban analysis, from essentially looking at data from 2007 to 2017, we wanted to give an estimate of what percentage of abortions would then be legal under this 6-week ban, if you will, in Georgia. And essentially what we found out is that it's a shockingly low portion. So from 2007 to 2017, on average in Georgia, around 33,000 abortions were provided in the state. And using estimates from 2016 to 2017, which are our most recent years of data, we estimate that around 12% of abortions provided in the state would likely meet the requirements for abortion care under HB 481. And that is essentially using that 6-week indicator as a marker. 12% of abortions would be provided prior to 6 weeks, so thus meeting that fetal cardiac activity requirement. But we know that the effects of these policies are not felt equitably, so we wanted to look at these inequities by race, age, and education. And unsurprisingly, what we found is that a smaller proportion of abortions obtained by Black people would meet the legal requirements for care under HB 481. A smaller proportion of abortions provided to younger people would meet the legal requirements, and a smaller proportion of people with less than a high school education or those who are high school grads would meet the legal requirements for HB 481. So in summary, essentially what we found is that the vast majority of abortions provided in Georgia will no longer be legal under HB 481, and that the law will disproportionately harm Black people, younger people, and those with fewer years of education. And I'm going to wrap this up really quickly with a study that was showing essentially what are the implications of very strict abortion bans on maternal mortality in the United States. This was done by a researcher at the University of Colorado. And essentially what they found was that a hypothetical total abortion ban in the United States would lead to a 7% increase in pregnancy-related deaths in the first year following the ban, and then a 21% increase in pregnancy-related deaths in subsequent years. However, as we've seen in all of these other studies, these effects are not felt equitably. And when looking at these numbers by race, we see that non-Hispanic Black individuals had a much higher rate of increased maternal mortality compared to other demographic groups, with a 12% increase in pregnancy-related deaths in the first year following a hypothetical ban, and actually a 33% increase in maternal mortality in subsequent years. So just to really wrap it up, this is kind of a quote from an op-ed that our center director at RISE wrote, but essentially what we know and what we have seen come to fruition is that overturning Roe has already created and worsened abortion deserts, including much of the South. And these policies is going to be disproportionately harming Black patients, other patients of color, and patients who are living on lower incomes. So that is it for me. And I am going to pass it over to Suba.
Yeah, thank you very much, Dr. Redd, for all of the information that you've provided and through the analyses that you've done. I'm gonna ask Dr. Verma to come on camera in order to present next. And then I'll also ask, panelists are going to present and then we'll have Q&A, but please feel free to introduce yourself in the chat or put your questions in the chat. Thank you, Dr. Verma. You can begin anytime.
Of course, perfect. I'm just, okay, I think, let me just go to the beginning. Perfect. Is that showing up okay?
Yep, looks perfect.
All right, Perfect. Well, thank you all for having me today. It's great being here with everyone. So over these next few minutes, I'm going to be talking with you all a little bit about some of the real impact of these abortion bans. And so more specifically, I want to use my own experience as a doctor who provides care here in Georgia. I provide full spectrum care. So I do pap smears, GYN surgery, labor and delivery, and then I also specialize in abortion and contraception care. So I'm going to use some of my experiences practicing here in Georgia to discuss the considerations that abortion restrictions are bringing up for us clinically and how they're affecting the care that we can provide to our patients. So I know we heard a little bit of background already, but I'm just going to briefly kind of set the stage here for what we're seeing in Georgia. So in Georgia, we are and have been facing a crisis in maternal and reproductive health. The unintended pregnancy and teen pregnancy rates in Georgia surpass the national average, and Georgia has one of the worst maternal mortality rates in the country. Within Georgia, people of color, people with less financial means, and people living in rural areas face disproportionately high pregnancy-related risks. At the same time, access to abortion in Georgia remains limited and restricted. So based on the most recent data, 96% of Georgia counties have no clinics that provide abortion, and 58% of Georgia women live in those counties. Current data do support an association between restricted access to safe and legal abortion and higher rates of maternal morbidity and mortality, with already marginalized populations experiencing a larger burden. And one of the reasons we likely see this association is that people with high-risk pregnancies who need to terminate for medical reasons may be less able to do so in states where abortion is restricted. And we also know that childbirth is riskier than abortion. And so when more people are forced to continue pregnancies to term and deliver, we expect to see more complications. In Georgia, where we face a whole range of abortion restrictions, the Georgia Maternal Mortality Review Committee has estimated that 60% of the state's maternal deaths are preventable. Even before Georgia's recent 6-week ban went into effect, Georgia has had multiple restrictions that have limited access to abortion care for many years. So those laws include things like mandated counseling, waiting periods, parental notification, ultrasound requirements, insurance coverage limitations, and then previously we had a 22-week gestational age limit that has now, as you've heard, gone down to 6 weeks. I do want to emphasize that even before the Supreme Court's Dobbs ruling, laws like this have been limiting access to abortion care for many people across the country for a long time. And doctors in these places have been dealing for years with ethical ramifications of having to figure out how to follow laws that directly violate our commitment to provide compassionate, evidence-based care to our patients. So I want to share an example of this by highlighting some of the real life impacts and ethical issues that have come up in my care of people in Georgia, even before our 6-week ban with some of these other laws. And then we'll also talk a little bit about what we're running into with our 6-week ban. So in Georgia, we've had a mandatory waiting period for a long time. And many states do. And what this means is here in Georgia, a patient must receive state-directed counseling that includes information that's designed to discourage the patient from having an abortion, and then wait 24 hours before the abortion can be provided. In Georgia, one of the silver linings is that we can do our 24-hour consent on the phone or by telehealth, whereas some states specifically require it to be done in person. But this law still creates huge burdens for patients and ethical issues for doctors. So we know based on the evidence that waiting periods serve no medical purpose. They are hurdles that are intended to make abortion less accessible. And so for all patients that make an abortion appointment with us, we call them before the appointment to try to review the 24-hour consent with them on the phone so that when they come in, they can get their abortion done that day. But we do have people that we can't get in touch with who don't realize that this law exists and show up for their abortion after taking time off work, finding childcare, finding a ride, scraping together the money to make all of these things happen. And I've had patients in this situation that come to clinic, many of them from surrounding states. And when we explain that we can't do the abortion that day because of the 24-hour mandatory waiting period, they're completely devastated and feel like there's no way that they can make it back another day. And again, it's terrible to not be able to provide this care because of a law instead of because of any reasonable medical reason. Georgia, like other states, does waive this waiting period in a medical emergency or when the individual's life or health is threatened, but not in any other situation. And so as the doctors providing care in Georgia, we have situations where we're trying to figure out when we can actually intervene to take care of a patient. So how sick is sick enough to bypass that 24-hour mandatory waiting period? So for example, if someone comes in after breaking their water at 16 or 17 weeks, which is a time when that pregnancy can never survive outside of the uterus, they might be having some bleeding, but they're not actively hemorrhaging. We're trying to figure out questions like how much bleeding counts as an emergency where we can go ahead and intervene. So instead of just being able to do the medically appropriate thing, what makes sense, we're trying to figure out how to interpret a law that has no basis in medical fact. And I think really, I want to also highlight some of the differences within the United States. So I did my residency in Massachusetts and then came back to the South where I'm from for fellowship here in Atlanta. And I think that really highlighted in Boston, these laws don't exist. And I think it really highlights for me as well how much the care that people can receive varies based on their zip code, even within the United States. We did hear a little bit about the 6-week ban earlier, so I'm not going to go into too much detail on HB 481. But just want to highlight that this did in July 2022 went into effect for the first time after the Dobbs decision. And so we have been dealing with this law now since July 2022 that bans most abortions in our state. So bans abortions in almost all situations after cardiac activity is detected, which is around 6 weeks for most people. There are very limited exceptions, which include medical emergency, medically futile pregnancy, and rape and incest if an official police report has been filed. So similar to the discussion around the 24-hour, I want to just highlight in these next few slides some of the specific things we're running into trying to navigate providing care for our patients with the 6-week ban in effect. So again, similar to that discussion around the 24-hour mandatory waiting period, we're having broader conversations about when we can intervene to provide an abortion under exceptions for medical emergency and medically futile pregnancy. So we as clinicians are constantly practicing making medical decisions in gray areas, and it can be really unclear to us whether we can perform an abortion for a particular patient under our state law's exception. So that question keeps coming up of how sick is sick enough? Do we have to wait for someone to get sicker before providing them with medical care, which is very contradictory to our training and our role as physicians to have to wait for someone to get sicker so that we can take care of them under our law. Just as many institutions did during the COVID-19 pandemic, we are talking about creating hospital task forces in many places and have created them in a lot of places to help clinicians make these decisions as questions come up in real time. And then we're also thinking about legal considerations around how to refer or transfer patients, particularly patients who are experiencing serious pregnancy complications, but may not be considered sick enough to qualify for care under our state's existing abortion restrictions. So for example, can we directly transfer a patient to an institution in another state or help facilitate that care? Or does that introduce legal liability for us here in this state as doctors practicing here? And, as you can imagine, when we can't provide indicated healthcare for our patients and are limited in our ability to facilitate getting them to someone who can, that brings up all kinds of ethical issues related to the commitment that we make to our patients as doctors. And then even with our very strict abortion laws here in Georgia and with this 6-week ban in effect, we're still seeing a lot of patients that are coming from surrounding states like Tennessee, Alabama. Even I've seen patients from Arkansas, Texas for care because those states have complete bans. And so we're also navigating issues around making sure these patients are safe after they receive care with us when they go back to their home states. We also know that legal restrictions on abortion are and will continue to affect a wide spectrum of patient care. So, for example, in states with laws criminalizing abortion provision, clinicians might be nervous about providing pregnant patients with needed diagnostic tests like radiology or interventions like anesthesia or surgery for a ruptured appendix during pregnancy, because they might be afraid of inadvertently causing a pregnancy loss. And they also might be confused about the impact of abortion restrictions on miscarriage and ectopic pregnancy management. And we've seen these laws affect people having miscarriages, people experiencing ectopics around the country. Even when abortion laws, these bans around abortion exclude miscarriage and ectopic, there's still all of this confusion that is created, and we are seeing effects on all of these different types of care. And then finally, we didn't become doctors to be tools of the state or law enforcement, but as more and more states criminalize abortion, many of us are raising questions around how we can make sure we can protect ourselves and our patients and avoid becoming enforcers of harmful laws. And so, we have an obligation to protect patient privacy, confidentiality, autonomy, and to prevent the criminalization of our patients. But some of these states are trying to pass laws that violate these ethical obligations. So these are just some of the things that are coming up for us that we're talking about. I'll stop sharing my slides and pass it back here.
Yeah, thank you so much, Dr. Verma. I really appreciate you talking about what your experience is in providing care. If I could ask Dr. Redd to come back on camera too, I feel like both of you all have given some really, really interesting information and two sides of the coin, sort of from a population level and then from almost an individual care level, right? But yet are clearly documenting like the same thing in tandem, right? So one of my questions, to Dr. Redd is, you have talked a little bit about how RISE is doing sort of projections in Georgia and a lot of trying to document what the likely outcomes have been. Has there been any work that looks at the health and well-being of families or children in the long term in these restrictive environments?
Yeah, that's such a good question. There's kind of a few different ways of looking at it. So one of the especially here in Georgia, biggest issues with our sort of perinatal health workforce or just kind of like the landscape here in Georgia is that we have huge deserts when it comes to OBGYNs, nurses, primary care providers, but roughly half of counties in the state do not have an OBGYN, which is horrifying, but the reality here in Georgia and has been for a long time. So, one of the biggest things that comes to mind in terms of, how does this affect families is that if you have people who are getting pregnant, and you have more people who are getting pregnant with limited access to abortion, who is actually going to be serving those patients when we already have such a limited, we are already experiencing such a limited workforce, especially for people in rural areas. It brings up these just like additional structural barriers to people actually being able to get, prenatal health care. And where are they going to deliver? We've had so many rural hospitals close here in Georgia. We just had Atlanta Medical Center close here in Atlanta, which was a huge labor and delivery unit. So, we have kind of like all these like layered issues that are kind of happening. But, in terms of kind of families and children, there's definitely much research has shown that being unable to obtain a wanted abortion actually leads to increased rates of economic hardship. So people are actually more likely to be living in poverty after not being able to obtain a wanted abortion and thus, carrying a pregnancy to term, which can then, and of course that can also disrupt just an individual's, kind of employment situation, their educational trajectory. So these are kind of some more like social and economic outcomes that can actually be affected by limiting access to abortion care. Of course, there's also just less autonomy. And I think, especially when you think about for kids, especially kids who are able to become pregnant, like not only is there, an increased stigma around abortion that of course has always been there in the US, right? Like that's always been something that we struggle with. But these laws even further increase the stigma around abortion, which can then increase fear. And, there's so many like psychosocial outcomes that can be affected by that. And then also, I don't know, kind of like in tandem, you're looking at like the sex education system, in Georgia here, we have promotes abstinence. That's the model. It's not a comprehensive sex education landscape. So, you have these like layers of elements that are kind of will be affecting kids and just kind of like increasing stigma, increasing fear, all of which just increases stress around getting pregnant.
Thank you, Dr. Redd. Dr. Verma, do you have any thoughts about the workforce related issues that are going to happen in Georgia? We have a few other questions too that I can.
Yeah, I mean, I think we are definitely going to see worsening workforce issues, both in terms of, I think training is another big thing related to the workforce. So in terms of residency training for OBGYNs, about 50% of residency programs are in states that have now banned or nearly banned abortion care. And so we're worried about our trainees not getting these essential skills. And these are, life-saving skills. So it's not just for a planned abortion case. This is also if someone comes in an emergency, we use these same strategies, these same skills. We use the same procedures for people having miscarriages. And so it's really important training for our workforce to be able to get. And I think we're definitely worried about access to that training for abortion care, for miscarriage care, for emergency care. And I think that's something that's really concerning. I've also talked to people that, like me, are from the South. They're really tied to the South, but they say, medical students that say, I'd love to stay, but I need to be able to get the training that will allow me to provide care for my patients, regardless of their needs. And so they are leaving. Like we're seeing these people that have these incredible ties to the South being pushed to leave because they need to get the training. They need to be able to provide care. And there is also this element, right, of moral injury. Like I've had my training, I feel very competent in providing all of this care, but the laws are telling me I can't. And there's, it definitely takes an emotional toll on us as providers to have to turn away our patients every day that we know how to care for. So to have to look at our patients and say, I have all the skills, I need to take care of you, I have the training to do it, but politicians are telling me I can't. And there is an element of moral injury there that does take a toll on providers, and I think will push people out of these areas more and more.
Thank you so much. I think we have a Q&A question. So one of the questions is, I'm confused. What's the goal of the affecting policy change from the research, Sarah? I think one of the questions is, what do you hope the outcome of policy change is going to, be regarding this research? I think a lot of times when we talk about population level research, people are confused about what's the point of like documenting this if there's no outcome in policy change here. So maybe you could speak to that.
Yeah, it's a good question, and I appreciate it because sometimes it can feel a bit futile to be, diligently trying to capture and highlight the effects of these restrictive policies, and presenting that information to legislators, to policymakers, and then certainly in Georgia's setting, basically them saying, we don't really care. And that's kind of just part of the fight to trying to like ever so slowly, little by little, chipping away at these sort of restrictive policies, these anti-abortion mindsets. The reality is that, you know, certainly in Georgia, we are living in a state with that is, you know, has a Republican, and certainly as of today has a Republican majority in every house, in every aspect. So, you know, the governor and the legislature are Republican led. However, one thing that I have learned a lot from the community here in Georgia, specifically like the reproductive health rights and justice community, is the you know, ever ceasing importance of just not giving up and not allowing them to win. Because if we say, you know, okay, well, they're never going to listen to me, I'm going to stop doing this research, it's not making any changes, you know, then they've won in a way. So, you know, part of it is maintaining the kind of like maintaining the drive to keep going and keep trying to have this, you know, change policy and help people. And another thing that I think is really important to highlight is that all of these studies have been used in actual like legal research. So, you know, there have been numerous what are called amicus briefs that essentially researchers or any invested party can actually file around a big court case. And so with the Dobbs versus Jackson Women's Health Organization, like there were hundreds of pages of research that were delivered to the Supreme Court justices for them to read and review. And unfortunately, you know, they didn't necessarily agree with the science. But we've seen in other states that there have actually been successful, you know, they've used research as one part of, you know, arguments to successfully overturn these restrictive policies. So, you know, partially it's like, well, we have to look at other states and kind of take a more macro lens to see that no, this research does actually help change policy. Just in Georgia, we're a little bit limited with the audience that we have. So it's a difficult thing. So yeah, but Dr. Verma, please jump in.
Yeah. No, and I was just going to say, and we know, right, that the majority of Americans support access to abortion, right? That's not necessarily reflected in the people that are elected, but the majority of Americans do support abortion access. And we're seeing that in these ballot initiatives in Kansas, now in Michigan, in Kentucky. And so I think part of what I'll think about with this research too is being able to speak to the public who can then, and it's a process, right? You're trying to speak to the public who can then in time elect people who better reflect those views. But I do think it's really important to do research that documents the negative effects and the harms of these laws, and then take that back to the public so we can really see what's happening. So like my research right now, we have a grant looking at the effect of this ban in Georgia on people with high-risk pregnancies. And we particularly chose that population because we felt like it is a population that that might resonate with the public, right? If we can really make a connection on this impact on people with high-risk pregnancies and a connection on maternal mortality and morbidity, where there's a lot of focus in Georgia right now, then maybe that can push the needle a little bit with policy. But it's hard, and I think it takes time and is definitely a process, but I think it's super important.
Yeah, I will just chime in and say also that question is sort of from a research standpoint, or like from a even a clinician researcher standpoint, if it is not counted, then it does not exist. Like if we do not document some of these things, even if they're historically important, this is a moment in which we are showing that our policies are not in lockstep with the general opinion and what those harms are. The documentation of that is also important, but I can give an example historically, at least. Prior to the Roe case, Georgia had Doe v. Bolton, which was also a case that was going up to the Supreme Court. And the data from that was all provided by Dr. Roger Roche at Emory, who documented all of the deaths from unsafe abortion using the Georgia pregnancy deaths reporting systems, basically. And that data ultimately stayed in the Georgia case, but similar data was used in Texas to bring the Supreme Court Roe case. So a lot of the behind the scenes stuff, this idea that like, we are talking right now about like a very hostile and restrictive environment, but I think I want to like ask the question to Dr. Verma, like from a federal perspective, like I think we do know what the makeup of like politics looks like at this point, but from a federal perspective, what are people, kind of doing too? What might be something that people can continue to watch or maybe support from a federal perspective that might support reproductive autonomy?
Yeah, so we've had federal legislation that has been proposed and like held up in Congress for a long time. So the Women's Health Protection Act is one that would protect access to abortion across the country. So essentially be federal legislation that does what Roe v. Wade did. And so something like that, I think, would be really important to protect abortion access across the country and prevent some of this like patchwork of laws that we're currently seeing, where some states have complete bans, some states have almost complete bans, some states have access. And so that is really, I think, the federal legislation that would be super helpful. It based on our makeup of federal Congress, like we haven't been able to pass that yet, and it doesn't look like something that we will be able to pass in the near future, but would, I think, be something that's important to support at the federal level.
Thank you. And I think the last thing, I'll give an example of local politics making a difference for. So a lot of this data, one of the things that we often forget is that local change can be made using information, and that's often like a place where there's a lot of change to be made. So in the city of Atlanta, they created a reproductive justice fund, which was funded by the city to the tune of like, I believe like $300,000, based on the fact that they wanted to create Atlanta as at least a safe haven city for the protection of reproductive health. And that was given to community groups to be able to be the stewards to communities who might be more marginalized than others with reproductive, like restrictive reproductive policy. So I think we're kind of trending towards, the end, but if there's any other questions, I'm so happy to like take them, but I do have a few other questions. I think in the spirit, I think we've been listening to a lot of webinars where we've documented a lot of the harms and talked about this. And I'm sure, the people on this call are like learning more, but also have heard pieces of some of this stuff before. Dr. Redd, from a community engaged perspective, what can public health professionals who might or might not be engaged in SRH every day, who might they consider supporting, or what might they consider doing?
Totally. I love this question, especially because I do think it's really important, particularly given with abortion, we've just had onslaught after onslaught of bad news, and especially here in Georgia. And so it's really important. Well, I guess I'll just speak for myself and say that like, it's very easy for me to kind of go in this negative spiral and just be like, oh my gosh, everything's screwed. What are we going to do? But one thing that has been truly like just balm for my soul is to get really involved in the community organizations that are fighting for abortion access, every day on the ground. And that looks like an important element to highlight is that Atlanta is one of the birthplaces of the reproductive justice movement. And so we have a lot of really incredible reproductive justice organizations that are fighting to protect not only abortion access, but, you know, they are promoting, you know, policies and care that is going to affect, you know, better people's lives in many different ways. And that includes reproductive health care, but that also includes, you know, housing justice, economic justice, you know, gender justice, like racial justice, making this very broad kind of push for, you know, any policies, services, programs, and supports that are really going to move justice, put kind of equity and justice smack dab at the middle of their focus. And so that looks like there are a couple of organizations that come to mind that I am involved with, and it's just really helpful to kind of do community work. Whether that looks like getting involved on a Amplify Georgia collaborative is a really wonderful group. And they host monthly reproductive justice community calls. And that's literally me on Zoom at 6 o'clock from 6 to 7:15 once a month with a beer, right? Like talking to people who are also interested in this work. And a lot of those calls are kind of mobilizing people to support different campaigns. One of their campaigns was the Atlanta City Council $300,000 donation to ARC Southeast, our local abortion fund. So, you know, there are a ton of different organizations that people can get involved in, whether that's just attending events or actually volunteering, or I think another, you know, important thing for people to do is in you know, your professional and personal life, really digging into the idea of reproductive justice and kind of you know, combating. There's a lot of dis and misinformation out there around abortion access. So just trying to talk, you know, counter those, you know, incorrect myths and misinformation if you do encounter them. But there, you know, and definitely if folks like need more kind of specifics of how to get involved, I'm more than happy. And like, please, Suba, share my email if people have questions. But I can definitely direct you like in the right directions for getting involved in community work.
Thank you so much. And Dr. Verma, if you could talk about the provider's perspective, how can people support physician providers or other abortion personnel during this time?
Yeah, that's a great question. And I do want to just emphasize what Dr. Redd said around like all of this is tied together, right? It's not, you know, so it's about postpartum Medicaid, expanding access to health insurance. It's about making sure our patients that want to get pregnant are able to do so and parent in healthy ways. Like all of this work is tied together. And I think that's such an important point to highlight. I feel like, you know, I think from the provider perspective, and I think getting involved in a lot of these organizations is great and super important. You know, I work a lot with Feminist Women's Health Center, which has a really important long history of advocacy in the reproductive justice movement and in the community, and ask for volunteers, people to help with some of the advocacy stuff. So getting involved in some of these organizations can be really helpful. If possible, you know, donating to local abortion funds, which we depend on a lot to help our patients get to the care they need. So those are some of the things that come to mind, and then continuing to like reach out to politicians, continuing to push for legislation that allows people to access this care and doesn't criminalize the providers like me that are providing that care.
Thank you so much. I think we have to end on that note, and I truly appreciate both of y'all's time. Thank you everyone for attending. Please feel free to follow all of us on Twitter as long as Twitter exists. And also our flyers contains everyone's emails. So don't hesitate to reach out to anyone in both the Georgia or DC chapters or any of us on this panel. Thank you. Have a great day.